Good morning all. Today I am presenting our experience at Regional Eye Hospital about iris claw lens implantation in Kurnool. And my co-authors are Dr. Salim Basha, Niharika and Chandana. And I have no financial disclosures to be made. And coming to this, and we have about 66.2% of avoidable blindness in the form of cataract in our country. And of this, 1.7% are aphakics. Now, aphakia is not acceptable because of the intraocular lens modifying everyday visual needs of the patients, and the prevalence of aphakia is secondary to perioperative complications during cataract surgery should be managed well to avoid complications of aphakia and their anisometropic complications. So, the challenge is to overcome this aphakia during the procedures. We have these situations like we can implant either a snail fixating IOL, either glued or a sutured one, or an anterior chamber IOL implantation, or the latest retro iris claw IOL implantation, retro or anterior. And other possible management options are keratophakia and epikeratophakia, which are not regularly practiced. And our objectives of the study is the instance of poor posterior capsular support due to PCR and zonular weakness, and the need for retropupillary iris claw implantation as a primary or a secondary procedure, and to assess the complications and visual outcomes with this retropupillary iris claw IOLs has been done, and to assess the technical feasibility as a primary procedure in cases of PC rents and weak zonular supports, and also as a secondary modality in managing pre-existing aphakia. Our inclusion criteria being patients with no capsular support or extensive posterior capsular rents, or with weak zonular support, and aphakic patients referred from other centers, and patients with PCR secondary to trauma. And exclusion criteria are comorbidities like insufficient iris tissue or thin iris tissue and neovascularization of iris, secondary glaucomas and decompensated corneas, and posterior segment pathologies. And methodology being it's a non-comparative prospective interventional case series study of retropupillary iris claw IOL implantation for a period of 1 year, that's from June 2022 to June 23 at the REDDY Regional Eye Hospital, Kurnool. And preoperative evaluation includes the general physical examination of the patient, the best corrected visual acuity and slit lamp examination, and biometry, and retinal evaluation, and intraocular pressures were evaluated. And our results are like, we have done about 3,000 IOL implantations during that period, and out of that 70 were retropupillary iris claw IOL implantations. This number looks big, but out of the 70 patients, 59 patients, that is 85 or 84% of the patients are posterior capsular rupture or vitreous disturbance perioperatively, and were managed with a primary iris claw IOL implantation after thorough vitrectomy. And 11 patients, that is about 16% of the patients were pre-existing aphakics, where we did a secondary IOL implantation with retropupillary iris claw IOL implantation. Most of the patients are in the age group of 50 to 80 years. And the amount of this is about 2.3% of the total number of IOL implantations we have done. And as I told you, and we have followed these patients for about 3 months after the implantation. And most of these patients had very good IOP, in about 67% of the patients the intraocular pressures were normal, and only 3 patients has raised IOP, and which was controlled well with topical medications alone. And visual acuity was good in almost 90% of the patients, so like 65% of the patients had vision between 6:9 and 6:18, and only 3 patients had poor vision, and the cause for poor vision is because of the severe AC reaction and endothelial decomposition in 1 case and cystoid macular edema in 2 cases. And pupil abnormality, that is gross ovalization of pupil or irregular pupils, was seen in about 7 patients, and iris abnormalities like the exposed haptics and at the enclosure site was seen in about 3 patients, and glaucoma was seen in 3 patients, which I have mentioned earlier. This is the table showing the complications which we have seen. And coming to the discussion, retrofixated IOL implantation has become popular among surgeons because of its viability, and also iris claw lens haptic lens is easier, learning curve is easier, and its implantation is simple, and as a primary procedure it can be done without much fuss in the theatre. The present review is based on literature and our clinical experience at our institution. And the focus on surgical techniques and outcomes, especially related to the characteristics of these IOLs, having haptics with the class or a small fissure which is for enclaving, and implanting retropupillary IOL has been relatively short, has a short learning curve. Retropupillary iris IOLs demonstrated generally a favorable efficacy and safety also. However, the outcomes are probably more influenced by the reason for surgery and comorbidities than the IOL itself. This is the lens design. This is a modified artisan lens with a vault upwards that creates a distance between the iris and the lens. And enclavation is easier in these lenses because there is a larger aperture between the optic and haptic, and the haptics are enclaved and attached to the virtually immobile middle of the iris. So it doesn't restrict the pupil dilatation and constriction. And this is the model of, this is the worst iris claw old lens, and the next to that is the artisan modified FK IOL. And this is the lens. This has a diameter of about 5 millimeters, and the optic size is about 5.5. The total body is about 5.5, and diameter is about a maximum diameter about 8.5 millimeters. And it comes from 14.5 to 30 diopters, and the sizes can be ordered for smaller eyes and pediatric age groups, and A constant being 115.0.
The time is up.
Indications in extensive journal dialysis and PC range, this can be a primary procedure, and the same sitting we can do the surgery, and it has good outcomes. And these instruments are required in our emergency set on iris claw forceps and enclaving rod. Thank you, sir.
Excellent data, and congratulations for those numbers. Your study lags behind on the scientific content. Like it's lagged behind the scientific content. If you see your aim of your study, it does not support the methodology which you have followed. So if your aim should have been safety and efficacy of iris claw, and you should have included that when the patient undergoes this particular surgery, and what is the methodology that you use for your surgical thing. Then on what follow-ups you are going to see the patient, and in each follow-up what are the tests you are going to do, like specular microscopy, OCT, fundus examination, and you should have given an average of endothelial cell count average of those patients, what were the complications. So this would have been a better methodology for your, so you have done such numbers. If only if you had included this methodology properly, it could have been much more meaningful.
Because of the time factor, we could not include most of the slides, sir. And ours being a teaching institution, we have a lot of PGs and trainees doing the surgeries, and so we have so many numbers of PC range and complications per operative.
If you included the numbers, it would have been a very good.
Usually we were doing it at a later stage. Now we have started doing it on the same sitting after doing thorough vitrectomy, and PA has been done at the non-enclaving site, whether temporal or so vertical. And this numbers itself just to show that iris claw lens is easier for even anterior segment surgeons to master the technique.